Hello everyone, my name is Kevin Fernando. I'm Education Director of GPnotebook Education. Welcome to our latest episode of our GPnotebook podcast. And actually this episode is a diabetes special, focusing on some of the key messages that have come out of the recently completed ADA, American Diabetes Association Annual Congress. And for this episode, I'm fortunate to be joined by some of my diabetes colleagues here. I've got Patrick Holmes, a GP in Darlington. I've got Amrit, Lamba, a GP in London, and we have Amar, Puttanna, consultant diabetologist in Birmingham. So I'm just going to hand over to them very quickly to give a bit more of an introduction and their background before we kick off with some of our key take-home messages. So Patrick, do you mind just telling us a little bit more about yourself?
Yes, I've been a GP partner for 20 years now in Darlington, originally from Leeds, that's my hometown, so I haven't moved that far. I'm a GPSI in diabetes, a CCG lead now for Tees Valley, and I also are involved in some clinical research as well. Good
stuff, cheers. Amrit.
Hi everyone, my name is Amrit Lamba. I'm a GP based in Barnet, North London. Have a specialist interest in diabetes that I've developed over the last 5 or 6 years. I'm one of the clinical leads for our community diabetes service and our GP Federation diabetes service as well. And yeah, it's my first virtual ADA, which it is for everyone, and it'll be interesting to talk about it with all of you.
Good stuff. Thanks for joining us, Amrit. And Amar.
Hi everyone, it's Amar Puttanna here. I'm a relatively new consultant, you could say, a couple of years now in Birmingham, part of the UHB Trust, and I have massive interest in diabetes, as most people will know, and especially medical education. My specific interests, I guess, are more kind of cardiovascular disease and older adults, but yeah, anything diabetes. And
so let's get on to the meat of the podcast. The ADA Congress. So, another great Congress. I thought overall some really interesting sessions. Still quite a dominance, isn't there, of cardio-metabolic renal medicine inevitably, and that certainly is a main interest of mine. But certainly some more other interesting sessions as well, out with that sphere as well. So maybe should we kick off with you, Amrit? Do you want to take us through maybe one or two key messages or interesting sessions that you think would be helpful to share, or as you said, to discuss, to try and refine that opinion?
Sure. Yeah, so I mean, going into this conference, trying to keep it as relevant as possible to primary care and to my own practice. So I was trying to look out for the SGLT2 inhibitors, obviously, and I know we're going to discuss that in some detail going forward. A couple of things that jumped out at me, the gifts that keep on giving from the EMPA-REG outcome, post-hoc analysis. The cardiovascular benefits that are seen, within 3 weeks, I think so, within 17 days, there's the first benefit seen in terms of hospitalization for heart failure. I thought that was quite striking, particularly at the moment. Locally, we are really trying to get our clinical pharmacists involved in terms of prescribing of SGLT2 inhibitors, and information and little taglines like that can really kind of send that message across of how kind of quickly these sorts of agents, in this case empagliflozin, can make a difference, and the real kind of detriment that patients could face if we are kind of lagging at all, if there's that clinical inertia. So that was really interesting for me. So there's that. There's also
just following on from that, I think, and maybe Amar and Patrick can help me out here as well. I think there's a number of studies currently recruiting for acute heart failure and SGLT2 use, isn't there? I mean, that, again, it's going to have significant clinical implications for our secondary care colleagues particularly. So, very exciting class of drugs in terms of its effect and the speed of onset. Absolutely. Sorry, carry on, Amrit.
Yeah. And I was just, without dwelling too much on SGLT2 inhibitors, I'll move on to something else that just caught my eye. It was use of the Freestyle Libre, and there was, I know, in England, it's really been championed by Partha Kar. We've, from my experience in primary care, my involvement isn't that much. It's, very much a secondary care initiated kind of initiative. But it was interesting to see a US study that looked at type 2 diabetes, the use of flash monitoring in type 2 diabetes, and actually how it reduced acute diabetes related events. obviously it was a retrospective study, and can't obviously say that there's a causal effect there, but just kind of potentially widening the scope of the use of Freestyle Libre just caught my attention. And again, something from my own experience of my own patients who have themselves privately gone and purchased Freestyle Libre, outside of the realms of the NHS criteria, the impact that it's made for those patients actually in terms of their engagement has been interesting. So this study really showing that potentially can reduce, acute diabetes related events, hypos, hypers, DKAs in type 2 diabetes caught my eye as something that would benefit the patient and potentially the health economics surrounding that as well. So those are just a couple of things, so many things that kind of did catch the eye, but those are just two things that I thought were quite interesting from a primary care perspective.
Freestyle Libre, routinely I hear the phrase life-changing from many of my patients. I'm not exaggerating here. It's something we regularly hear in primary and secondary care about the impact of this. So, Amar, do you want to take us through maybe one or two key sessions or messages or items of note that you took away from the ADA?
Yep, as Amrit was saying, and you've been saying, it's always been heavily focused on cardiorenal and metabolic kind of side of things with SGLT2 inhibitors and GLP-1s. I will talk about one of those sessions, but the one thing probably I found interesting, perhaps not for now, but for the future, was a presentation on weekly insulins, and specifically a new weekly insulin called icodec, which I remember when the initial first ultra long-acting insulins came on, there were thoughts, maybe we could use these once a week or less frequently, and that didn't work out. So something like this kind of slipped my radar, and I found myself seeing, there is something, a weekly insulin. And they compared icodec to glargine and looked at it, and what they found was fairly consistent and similar HbA1c reductions with it. However, slightly more hypos, and that's probably the main concern that people were saying with weekly insulin is if you have hypoglycemia, how are you going to adjust the dose? How are you going to reduce it? If someone's going to go into an unwell state, or if they're in hospital and then things change, how are you going to adapt and change things? And I don't think I have an answer. I don't think anyone had a clear answer. Stefano Del Prato did an excellent kind of summary talk on this. I'd recommend it if anyone's going to has access to ADA, and said it's the start of something, and it's going to be refined, and there are going to be phase 3 trials now on the back of this icodec data, and I'm keeping an eye out for the future, because the possibilities are there. As you know, I deal with frailty in older adults and try and simplifying regimes. If you can get something that's once a week from an insulin side, and perhaps, who knows, other medications that are injectable, such as GLP-1s, combining them would be an interesting concept. But also even third-party administration, that would be something that would save a lot of money as well, potentially.
You can tick your bingo card here, but that would be a game changer for our district nursing colleagues, wouldn't it? Particularly given the pressures we're under in the pandemic. But if we can reconcile insulin to once or even twice weekly, to be honest, would relieve a lot of pressure. Would you agree, Patrick?
Yeah, I would absolutely agree. But I think, as Stefano Del Prato commented, his final slide was, we've got a long road ahead. And I think there's a lot that this issue about hypoglycemia concerned me. We're moving away from average glucose in terms of HbA1c, certainly in type 1 diabetes, increasing it's about time in range, and there's increasing evidence. In fact, there was some evidence about time in range, which came actually from 8-point testing from a cardiovascular trial. It was post hoc stuff, but it showed time in range made a difference when it came to mortality in that study. And it's a slight concern in the sense, if we've got people going outside of range for the convenience of once weekly. So it felt, there's a superficial attraction. I think I'm more with you, Kevin. You said it'd be nice if we got a twice weekly one, if it works well. We sometimes, I suppose, we've had drugs which are sold as truly once daily GLP-1s, and actually they're not, and they don't work very well. And we've got insulins which aren't fully once daily, and yet they're sold as once daily. So I think we should be treating the patient, but I know certainly once weekly GLP-1 has changed my prescribing. And if the insulin is just as safe, it would be hugely welcomed. I think when particularly patients when they're first starting treatment, and you can get away probably with an insulin basal, you might be able to treat them earlier and therefore avoid a lot of the problems which we deal with later on, which are so expensive financially and to the poor old person who's living with the condition.
Was there another session you wanted to discuss, Amar? Was there anything else?
There was one on DAPA heart failure. I don't know if Patrick was going to go into that, but that was one of the sessions that interested me.
The DAPA HF update, you mean, that session?
Metabolic outcomes from DAPA heart.
I was keen to, we discussed that. Some really interesting stuff within that, wasn't it? And I've written a little review of that already, actually. So go fire away, go for it too.
Yeah, no. So for those of you who don't know, DAPA heart failure is the trial looking at dapagliflozin, the treatment of heart failure in a HFrEF, say reduced ejection fraction heart failure, in a population of patients who either had no diabetes or a history of diabetes. So 42% or so people had a history of diabetes, but a large number, 55%, did not have known diabetes, of which there was a 3% undiagnosed diabetes that they uncovered in the trial. But 55% of people did not have diabetes, and so as we know, DAPA heart failure showed that dapagliflozin reduces hospitalization for heart failure in all patients effectively. But this was specifically looking at those who did not have diabetes. And specifically the incidence of new onset diabetes.
Yeah,
and there was
really fascinating. Yeah.
Exactly. And I remember when it came out, the DAPA heart failure initially, I thought, I want to know what's going to happen with the group who are at risk of diabetes or don't have diabetes, because we know about importance of diabetes, type 2 diabetes, let's make that clear, type 2 diabetes. Diabetes prevention, we know a lot is going on across the world about type 2 diabetes prevention. So where would this fit in with that? And this is a way in a controlled trial to see the effects. And what they did find was dapagliflozin did reduce the incidence of new onset type 2 diabetes, which was very interesting, led to a lot of kind of considerations. Where do you place this then in terms of heart failure medication? Do you prioritize certain people, or do you, I use that word, quite argumentatively in a way, is it everyone heart failure, or do you say, well, this person's got diabetes and heart failure, this person's got borderline diabetes and heart failure, they may have added benefit on top of the heart failure effects. Mm-hmm. So where do you place this? This is something that's worth considering. Now, it's important to remember this trial was not designed or powered essentially to look at this. It's just an outcome, a secondary outcome that they looked at. So there's a lot of holes in some of the trial methodology because of that. But based on HbA1c, there was some changes, and it's something for the future.
Oh, definitely. Mm-hmm. And effect was more pronounced in those who had pre-diabetes, wasn't it? As defined though by the ADA criteria. So they have a slightly lower HbA1c, don't they? 5.7 and above. But nevertheless, quite compelling. And I think off the top of my head, it was around about 31% relative risk reduction, wasn't it? In terms of the benefits, similar to what we saw with metformin in the diabetes prevention program. So, fairly compelling. Part of me thinks, though, we're making a rod for our own backs, though, Amrit. What do you think? To be honest, I hardly ever use metformin for diabetes prevention anyway, to be honest. Occasionally in some of my, Asian patients whose HbA1cs continue to increase. But otherwise, I'd very much try and focus on the lifestyle and signpost to relevant lifestyle intervention programs. But what are your thoughts? Could you see yourself using SGLT2 inhibitors, perhaps even out with the context of heart failure for diabetes prevention?
I think it's tough enough at the moment to initiate metformin, let alone anything else. And I think that's perhaps a cultural change would be required within primary care in terms of the management of pre-diabetes, or however you want to term it at the moment. But yeah, I think that's a tough that's a tough one to sell, I think, to primary care.
And being a bit cynical, I'll come in here because, I mean, we've seen glucose. I had a debate, again, going back on Twitter. I've just had a debate with a professor in cardiology. So it's always good as a GP to start teaching professors in cardiology things about diabetes. But they were saying, oh, wow, you've got this. What's the mechanism of action? I said glucose lowering. I mean, it's a glucose lowering drug. Metformin works via glucose lowering. Pioglitazone has been shown in a randomized controlled trial to prevent diabetes. And, Acarbose, but that works in preventing diabetes. But I think answering your question, I think the two things really. One is I think SGLT2 inhibitors, and we'll come on to this, but they have obviously other benefits. So I think in some patients, particularly if they've got, let's say, heart failure, or there is perhaps evidence that they've got some, this is developing evidence, but it may work in protecting kidneys outside of diabetes. We just have to watch this space. Some trials are coming out. One actually trial came out just today. So it was just a very short one, but it does look like they probably do work outside of diabetes. And in terms of renal protection. But the beauty is, if obviously you've got these patients, if they're pre-diabetic or whatever word we want to use, the amount of glucose they're going to pee out is a lot less. So they get less side effects. So they actually compare to, so why don't we use metformin? It's twice a day. It's cheap. It's twice a day, but it's not the easiest drug. It's a very effective drug, but if we can give it once a day, very easy, take one which gives them other benefits, then yeah, why not? I'm a Yorkshireman, so as I've said, so if we buy one get one free, I'm all for a bargain. So if we can treat more than one condition.
Amar, sorry, carry on.
I just want to make it clear, I'm not advocating the use of SGLT2 inhibitors for diabetes prevention.
I know.
I'll make it clear for everyone else who's listening. But it's an interesting concept of stratifying, I guess, patients and heart failure. And those with heart failure or why you're concerned about heart failure, you can look and see where you go with that. So it's interesting, and I'm happy to have that debate in a different session.
No, that was just me getting carried away. I mean, of course, the inclusion criteria was HFrEF. So these individuals had pre-diabetes with HFrEF. So that is very important. But nevertheless, very interesting, for the ongoing discussion of the management of pre-diabetes. Now, the other thing I liked from that DAP-HF session, there was some really good practical advice about what to do with diuretics when adding in dapagliflozin, specifically, of course, when we talk about DAP-HF for the management of heart failure. And the answer was not much, really, was it? I mean, that was a reassuring message that there was very little early or even later tweaking of diuretic doses, even for those individuals on quite high doses at baseline. So again, I thought that was a very helpful and pragmatic message for both secondary and primary care. What were your thoughts on that, Amar?
Yeah, so they specified when they were talking that they had a 2-week follow-up after the initiation, purely for the diuretic and that side of things to make sure. And they said, essentially, they didn't need to make any real changes. It was based on assessment of the patient, and majority of patients didn't need any particular tweaking, and if so, it was very minor. So we were reassured. There's a lot of debate and query about what do we do with the diuretics, and a lot of these patients will be on. They may be on a thiazide diuretic, they may be on a loop diuretic, and maybe also on an aldosterone antagonist. So spironolactone. So I think it answers, in my mind at least, what I've been doing, and just being sensible and pragmatic about it, and saying, if you notice if you're noticing any difference in your volemic state, your volume status, in how much fluid's going on, how much you're weeing out, or how much you're not weeing out, then it's important just to alert someone about that. But I don't think I think it's reassured me that there's nothing too concerning.
Yeah, no, absolutely. And I thought the other interesting point John Murray made was, and I suppose it really re-emphasizes that in the context of heart failure, SGLT2s work in a very different manner, not dependent on glycemia. They just didn't see the same sort of urinary frequency, the mycotic side effects, UTIs. Wasn't that right, Patrick? It was pretty clean. I think, paraphrasing John, it was a pretty clean safety profile overall. Yeah.
Yeah, I mean, I think, and we've seen that in other trials as well, presented maybe not at this conference, but at others. If you've got, so those patients with very marked renal impairment, with EGFRs below 45, they're not, these drugs aren't very good glucose lowering because you're not peeing out the glucose, but they may still work in other effects. But one of the beauties is you don't get at least that mycotic infection problem presumably because of the lack of, or the marked reduction in glycosuria. And again, if you're giving it to patients who don't have diabetes, the amount of glycosuria is again reduced. So some of the problems we see clinically, particularly when patients got relatively high glucose levels, we don't see with these patients. So yeah, I agree. These are useful agents in people who don't have diabetes, and maybe prevents them joining the diabetes club.
Yeah, absolutely. So I'm just conscious of your time. Very much again appreciate you joining me. So I wanted to quickly talk about Virtus, but Patrick, was there any particular sessions you wanted to highlight quickly?
Well, very briefly, mine are very SGLT2 focused because it is the gift that keeps on giving. So, and this is based partly on because I tweeted a lot, and actually I just looked at which ones people seem to pick up on more, and therefore there was interest out there. And so one thing which I think is really important actually came from Credence. So this is the study which showed with patients with macroalbuminuria, so with diabetic kidney disease, with macroalbuminuria, I think the license is coming very soon, I think in the next month or two. So this will be available to be prescribed in the UK. There'll be a change in license of canagliflozin 100. But these drugs work a bit like ACE inhibitors in terms of they reduce the intraglomerular pressure in a different way from ACE inhibitors, but you do get a drop in the EGFR just as you do with ACE inhibitors and ARBs. Now we know a certain drop is actually often a good thing actually when we're starting ACE inhibitors and ARBs, and this appears to be, at least it's not a bad thing when it comes to SGLT2 inhibitors. So as long as the number is below a 30% drop in EGFR, it's absolutely safe. So that was a reassuring thing for a class of drugs, and they're often in quite sick patients. So, I think knowing this is reassuring. I can remember having a conversation with you, Kevin, about this a couple of months ago, and now we got the answer. So that was useful. Then there was a wonderful little study which was very popular, which was actually about, these were sick patients. So they were patients with type 2 diabetes admitted to hospital, either with established cardiovascular disease as a comorbidity or at very high risk. But these were hospitalized patients, started on SGLT2 inhibitor, then it was a randomized control trial, and they looked at their walking distance and their fitness after at 6 and 12 weeks. And there was a marked improvement by just giving an SGLT2 inhibitor. Now, whether that's because it's improving, I suspect it's a heart failure drug in these patients who may have silent heart failure, which we haven't quite diagnosed yet, but there was an improvement. And again, it's good to have a drug which improves people's symptoms.
Yes.
And then the other was the first one I've seen is that there was evidence from an SGLT2 study. Again, this was with dapagliflozin, which actually in a randomized control setting, they reduced some fibrosis markers. These patients with NAFLD, they weren't just changing enzymes, they were actually changing more robust fibrosis markers. So it's, again, it was just one first study, but that was very popular. So I think, and then I'll throw another one in. There was some evidence, again, from the EMPA-REG study. It's post hoc stuff, so this is really to generate ideas rather than this being evidence. I get that out there. But which showed there was a reduction not all in people developing sleep apnea during the study. So, and I suppose we'd expect that if it's losing a bit of weight, etc. But again, if we've got a drug which in patients who are heart failure don't have diabetes, it prevents them developing diabetes, and then in patients who've got diabetes, it might prevent them from getting sleep apnea. These are all good things, and these things are beyond the glucose lowering. Well, certainly the sleep apnea is beyond the glucose lowering effect, and I think. We as GPs, I think we know there's a lot more to particularly type 2 diabetes than glucose. So it just fits into my little worldview.
Great. Thanks so much. Amrit, do you want to add anything else? Anybody want to add anything else before we sort of finish off with a quick discussion about Virtus CV? Nope, good stuff. Okay, so this is probably where you definitely will need your bingo card, Amar. Discussion about Virtus CV, and I'm sure many of the listeners will know or have some idea about Virtus CV. It's the cardiovascular safety trial for ertugliflozin, the fourth SGLT2 inhibitor to market in the UK anyway. And this, of course, was on these cardiovascular safety trials, of course, were back on the 2008 FDA guidance that mandated cardiovascular safety trials for all new diabetes drugs. But actually, just to digress a wee bit, there was that interesting cardiovascular session, wasn't there? A trial session on the first day of the Congress. And it appears that the FDA have rescinded really much of their original guidance, and there appears to be a shift back towards perhaps glucose lowering. We're talking smaller numbers of people in trials, shorter duration of exposure. Certainly Steve Nissen didn't like the sound of that in the session, didn't he? He was his usual self, quite furious about that, saying it was a retrograde step. But which part of me agrees with, but part of me also thinks these trials are eye-wateringly expensive, aren't they? I mean, I don't know, Virtus CV, over $100 million anyway, isn't it? Or even upwards again. Is that a good ethical way of spending that amount of money? So, I mean, very quickly, I know I'm digressing again. What are your thoughts on the cardiovascular safety trials? Do you think they should be here to stay? Or do you think the FDA was right to relax, perhaps, the criteria?
It was an interesting session because they had quite a balanced argument, didn't they? I mean, we wouldn't have got this wealth of data that we got from the cardiovascular outcome trials from the last few years. But you make a very valid point there about the sheer expense and potentially whether moving forwards, go back to that phrase, a hybrid version of trials. Literally, just as I said that, like thunder and lightning has struck in London. That's what I would say. I think very valuable of what we've got from the last kind of few years of cardiovascular outcome trials, but there's certainly something worth bearing in mind in terms of the future.
But Patrick, you'd be bereft if they stopped cardiovascular outcome trials.
I think I wouldn't know what to do. Absolutely. And as you say, that we wouldn't have discovered about all these things that SGLT2 inhibitors do. I mean, as I can remember, someone described it as really a fantastic heart failure drug which protects kidneys, which has a side effect of making you pee out glucose. And I think increasingly that's often where we're looking at some of these things, GLP-1, it seems to reduce stroke, and why, and and how, so I think they offer so much, but as you say, they're so expensive. And I think, if you look at the price, so who's paying for it? It's the Americans. The Americans are paying for this, and we're benefiting from it in Europe and these. So, and that's, if you've got Donald Trump, if he gets another round of elections, is there for another 4 years or whatever. You can imagine he doesn't really want to be subsidizing the world with the American taxpayer, essentially, or the person who's paying for their insurance. So, but questions still go on about, does metformin truly protect are the findings of UK PDS? Because it was small, it was a well-run study, but long. I think my only comment on this is actually Ben Goldacre. So I quite like his view on this, which is that we should be almost having sort of pragmatic randomized trials handing in surgery. So you press a button and it tells you what to prescribe, and then it records it. I don't know where patient choice comes in all of this, but I don't know how we can, these are massive trials, so they cost so much. So it's got to have to change. You're going to say, Amar?
Sorry, yeah, go.
No, it's interesting because these trials came about from a safety side of things, purely from rosiglitazone, as we know. And it's answered that question, hasn't it? We had one trial, rosiglitazone, which was looked at, but then all the subsequent others, as they argued, all showed safety. So the whole point for having this, the whole basis for which you had the FDA change their guidance, is been proven to be, well, there's so far nothing to worry about. So you can see why the argument is there. Now, you ask, should we be changing things? Well, in a way, does it matter in a way? I know Stevenson mentioned that it will change things, but if you're bringing a new medication to the market, or you're bringing a new SGLT2 inhibitor, as we see with ertugliflozin, you almost have to do a cardiovascular outcome trial to be on level level with the others at this point.
Yes.
If you don't do that, then it's the rod that will beat you with and say, well, you haven't done one. And so you're damned if you do, damned if you don't, in a way, in that setting.
And the FDA were quite clear about that. The FDA representatives were quite clear about it. They said that, they're not, they're gonna deliver the same robust outcomes, so there's not going to be any shortcuts. Absolutely.
Mm-hmm. And when we get pragmatic trials, or kind of we get more from the trial, so not just looking at cardiovascular outcomes, a whole variety of outcomes if we can, and so we get more bang for your buck in a way, if that's possible. Good stuff.
So over to Virtus CV then. So again, conscious of time, so I've got just one question really from each of you. As we know, ertugliflozin, Virtus CV, met its primary endpoint of non-inferiority with respect to MACE. But really, I suppose there are two questions that seem to have been dominating Twitter. I mean, the first of all is this issue of cardiovascular death. So now we have 4 SGLT2 trials, Patrick, and really only one of them has demonstrated a significant improvement in cardiovascular death. What are your thoughts on that? It appears now that Empereg is the outlier.
I'm certainly quite happy to take this. Yeah, absolutely. I think it looks like Empereg is the outlier.
Yes.
It's now, and that raises more questions, I think, about Empereg than it does about the others, because that's the odd one out now. And that was clearly demonstrated with a meta-analysis they did to accompany the data. It was an update of a previous meta-analysis, but by Thomas Zelinka, or Zelnicka rather. So it raises questions. And again, going back to Twitter, so there was, I knew there'd been some issues about the adjudication of the cardiovascular deaths. And you've got to remember that Empereg only just achieved its primary endpoint statistically significant. It was 0.99. So if it was 1, then you could have said, well, you can't rule out that there isn't, statistically it wouldn't be significant. So and half of the adjudicated, the unexplained sudden deaths were adjudicated. Well, they were adjudicated as cardiovascular, and the FDA looked at this. Something I learned only just in the last few days since then. But the FDA looked at this, and half of them they reattributed to be non-cardiovascular. Subsequently, but even if we've got half where we're not quite sure, that may make a difference. So I think it asks more questions about Empereg, and therefore, do these drugs in these patients actually do prevent death, or is there something magical about empagliflozin? And certainly I don't know what the answer to that is, but it's interesting because we don't know. So.
Well, I think just to point out though, in terms of the adjudication for the unexplained deaths, that was allowed, wasn't it?
Absolutely.
Yeah. I mean, it wasn't the investigators going rogue. That was accepted practice. Yeah.
Yeah, but I think it's been applied slightly differently in different studies. So I think that, and you've got to bear in mind, some of this is the minutiae of clinical trials, but because we base so much on the outcome, the headline on these trials, it is worth getting clever people to dig deeper. So I'm not saying the Empereg trial doesn't stand it. The results are there; they're statistically significant. But you've just got to bear in mind, my view of SGLT2 inhibitors is they exert their cardiovascular benefits through heart failure improvements, really, but the mortality benefits are obviously really important to patients and to clinicians treating those patients. So it's an important answer for us to try to find, but I don't know. The only way to, and Mark Cooper, who reviewed this, Professor Mark Cooper is a professor down in Melbourne, who reviewed it, he did point out that the only real way you're going to get this answer is doing a head-to-head trial. Well, that's never going to happen. Dapagliflozin goes off generic in 3 years' time, so I can't imagine that company is going to spend the next 5 years answering that question unless it has to. And the same with the manufacturers of empagliflozin.
Great. No, thanks for that answer, Patrick. And then, Amar, the other question I wanted to ask you was about the renal composite. We've seen a real consistent message across the class, renal benefits of SGLT2 inhibitors. But yet in VERTIS-CV, we didn't see a significant, there was no positive renal composite endpoint. What were your thoughts on that?
Yes, I mean, it was that was actually one of the more interesting analyses from the trial in a way. Yes. We had hospitalization for heart failure, which matched what we know previously from the SGLT2 inhibitors, but the renal composite, which we've seen, which actually has mirrored hospitalization for heart failure in a way, like all the trials have shown some benefit in renal endpoints or renal composite endpoints from each of the other medications, but etugliflozin did not show that. It showed a trend towards it, but it didn't show any significant reduction in a way. And one of the key things to remember is that all these trials, though we say they're SGLT2 inhibitor cardiovascular outcome trials, they're all slightly different in a way. Yes. Firstly, I mean, we have no head-to-head, but in terms of, I guess, the population they're looking at, we have empagliflozin, which was 99% or low to 99% had established cardiovascular disease. And this mirrors that. So this is the only one that mirrors the same population, whereas the others had a combination of primary and secondary, had primary secondary prevention, so to speak, as an outcome, as one of the features. What we don't know in a way, and what we know from VERTIS-CV, is that a large proportion of the baseline characteristics of the groups had a high degree of heart failure. We don't know a lot about the underlying other medications that were in the trials, in the placebo group, the add-on therapies that were put on, both from a glycemic point of view and also from a cardiovascular point of view, any other medications that were changed. I don't think that information was presented. So we don't know if there was a difference between them, which might explain the impact. But the honest answer is I'm not sure. I don't know exactly why there's a difference when everything else matched and the heart failure hospitalization was just the same, just as good as any of the other SGLT2 inhibitors. I'm inclined to believe it's a class effect, but I can't explain why this one hasn't. And is it an idiosyncrasy of this trial? Is it something else? Time will tell. We'll find out more information from VERTIS-CV. But yeah, it's a quirk, and I don't know.
Just part that thought about class effect, and we'll finish on that actually. But I was going to go over to Amrit now. Certainly from a primary care perspective, I was pleased to see though the safety profile in VERTIS-CV, particularly no imbalance, I should say, in the lower limb amputation. So, do you think we can safely put this issue to rest now, Amrit? And if you can also comment on the rest of the sort of safety profile highlighted in VERTIS-CV, which overall was reassuring, wasn't it?
Yeah, absolutely. As you say, it's a very important factor in primary care. I suppose primary care clinicians generally are the ones who are prescribing this class of medication. So pretty much in line with the other trials, as far as slightly more greater numbers of genital tract infections, urinary tract infections, we know about that already. Yeah. But as you picked up on, there was no signal for lower limb amputation, which has been a concern in the previous studies, obviously the cardiovascular outcome trial for canagliflozin. So there's no signal there, no signal for DKA, which during this current period, there has been some discussion during the COVID-19 pandemic about any concerns of initiating or having a patient continuing on a SGLT2 inhibitor. So that was very reassuring. So no difference there between the intervention and the placebo group. And then Fournier's gangrene, which was something that obviously kind of quite alarming previously, but again, no signal found there at all. So overall, and fractures as well. Again, no signal found for increased risk of fracture. So overall, very positive findings in terms of safety profile, quite reassuring for our primary care colleagues. And hopefully we'll put to bed some of the debate that we've seen. But again, I have this, I try and look at every trial on its own merits and looking at the individual agent that we're looking at as well. So this is very much etugliflozin. So how much can we kind of draw parallels completely to the other agents? I'm not sure, but it would seem quite a positive finding for the class as a whole.
Absolutely. So a nice way to segue into my last sort of question or two then. class effect or not? I mean, this is a $64,000 question. This is also being all over Twitter. So we'll just start with you, Amrit. So SGLT2 effects, the cardiovascular benefits, the renal benefits, perhaps some of these other benefits we're hearing about in terms of diabetes prevention. Do you think this is a class effect?
I think
Mark Cooper's.
Yeah, I'm going to go to Mark Cooper's. Kind of, maybe. I think it's answered many questions. I suppose in terms of glucose lowering, it's the molecule itself. So yes, I think what we also have to acknowledge, though, as Amar pointed out, it was a very similar kind of baseline characteristic to the EMPA-REG trial. But there are clear differences in the primary outcomes and also in the secondary outcomes. So there are some unanswered questions there. I suppose the only thing I'd add to Amar's point is that the number of patients with heart failure were far greater. And I don't know whether, and perhaps that's something we could discuss, whether that had any influence on the difference in results that we saw. And also, I'm not a statistician, and some of you may have figured out already, but there was a lot of talk about the confidence intervals and, the confidence levels around the mean when it came to the analysis. And I think that if any of you have any comments about that, particularly in kind of distilling that for the primary care audience that we have today, because those were the hotly debated areas of analysis, which prevented, I think, Mark Cooper from saying, yes, it is a class effect, and in a sense prevents me from saying so as well.
Patrick, I think you'd commented on a few of those points on Twitter. How did you?
Yeah, so I mean, I think, so for me, I mean, answering the question, is it a class effect? I'm also with Mark Cooper, so he's a professor in metabolic medicine. But I mean, his was probably. So it is. So it's a bit like your Heineken advert or whatever it is. It's not Heineken, actually, it's Carlsberg. But anyway, we're not so. Let's go with all of them. They're probably, and it's a marketing term, probably a class effect. The only thing for me which stands out is that CV death, which I've mentioned. I think the rest broadly fall in line. The issue of confidence intervals and variation around the mean, it's worth pointing out that, so the smaller the study, the less certain things are, often the broader the confidence intervals, depending on the number of events and what have you. The smallest of all the cardiovascular outcome trials involved with SGLT2, I believe, is EMPA-REG. So, it is the smallest one. Other things changed. The time of when it was done, Mark Cooper pointed this out, that, that blood pressure treatment has improved in terms of the SPRINT trial, which encouraged, particularly in North America, and a lot of these people who were recruited were in North America. So I think, so their blood pressures may be a bit lower, which again might reduce things like CV death, MI. We know these things can make a different stroke. So therefore, and for that matter, heart failure hospitalization. So by better risk factor management, you might sort of just reduce the overall effect size on the placebo arm or the control arm, as well as the active arm. And then they start looking less and less. And going back to that heart failure case, if you've identified more, I think it was something like about 10% in EMPA-REG, it was about 23% in inverted CV. So quite big different numbers. Yeah. And maybe they're going to be on better treatment for that heart failure, which again reduces the benefits. If I'm right, and the main benefit of this, and of course with heart failure, people can die suddenly. If it's all about just improving that care, then you might actually not get the effect, and therefore the studies, even though it was relatively big compared to EMPA-REG, you might need even a bigger study. And that's where we come back to these meta-analysis to try to lump all of these things together. But what came out of that meta-analysis? We still can't explain that CV death. So that's why, going back to the beginning, I'm still uncertain. But it's fascinating.
Yeah, you're essentially saying it's a law of diminishing return, don't you? We've got too good almost at reducing future cardiovascular risk, especially in the context of heart failure. sacubitril valsartan, and also a 5% absolute risk reduction. And then, of course, we mustn't forget the ACE inhibitors, ARBs, spironolactone, the devices. So you're right. Perhaps it is a law of diminishing returns. Amar, what are your thoughts? Is it a class effect?
You can throw in colchicine into that if you want to. Uric acid and all that. But, yeah, so I always think about, kind of reproducibility when you talk about trials, don't you? It can be reproduced. Now, the problem is all these trials were done with different populations. So this is the first trial you have, which somewhat reproduces what was done before. However, we know a lot more now. So I wonder if you were to do EMPA-REG again now, would you get the same? I mean, you never can. Would you see the same effects? And I can't answer that question, to be honest. I can't say, yes, we will see the exact same. In fact, I don't think we would. But that's just a thought. My thoughts on the class effect are kind of between heart and brain. Heart says, yes, it's a class effect. The brain says, well, there's not enough evidence to suggest it's a class effect. And so that's where I'm struggling. I think heart failure and renal are probably, heart failure's got the clearest data of everything now from everything.
Yeah.
That there's a consistent effect in that. So that's a given in my mind. Renal outcomes, yes, I'd like to think so, especially from what we know might be coming soon. But in terms of CV death, 3-point MACE, and that side of things, I don't know. I'm not sure if that is just something. Yeah, I can't be confident in saying that, but I can be confident in the other two, which is where we are. And I think I'm inclined to look at EMPA-REG and say, well, and leave it at that. Yeah. But it's interesting. It's fascinating. We'll be talking about this for years probably, and certainly next year. But yeah, I'm very much saying with Amrit and Patrick and probably yourself that.
Well, it's only fair if I give you my opinion. And I've got to say, I think it is a class effect. There you go. Okay. And I think, we will be talking about this for many years to come, but we've got lots of lives to save now, don't we? Lots of work to do now. So I think, yes, let the debate continue, particularly amongst the geeks like us. But, we need to put this into practice now, don't we? And I'm not saying we mustn't practice evidence-based medicine, or what I prefer to call evidence-informed yet patient-centered medicine. So, of course, for my heart failure patients, currently the evidence best supports dapagliflozin. For my renal patients, the evidence best supports canagliflozin. And for my atherosclerotic patients, particularly if I'm worried about CV mortality, the evidence best supports empagliflozin. But that's not to say there's not a role for ertugliflozin, in that individual newly diagnosed with type 2 diabetes who have, titrated up the metformin, no particular other cardiovascular risk factors. There's a place for ertugliflozin for that individual. And of course, we mustn't forget the USP of ertugliflozin. The big USP is the price, isn't it? Yeah, to 20% cheaper. Flat price, both doses. So, we mustn't forget about that. But it does call, I see lots of hands here, don't worry, I'll let you know. So I'm not saying it's an easy decision, but I think, yes, let the debate continue, but we do need to start implementing all this data. So, yeah, Patrick, you go for first.
Well, there are two things. So price, of course, I've already flagged up that dapagliflozin is going to go generic in 3 years. So I think that's worth thinking about. I'm a Yorkshireman, and we got to save some money, and that's a good way. And nobody likes switching patients from one thing to the other. So that's something to bear in mind.
I didn't realize it was so soon, to be honest.
Yeah. Well, it's in 1 year in the United States. For Europe, it's 3 years. So, and in terms of, unless there's some funny things they do with license extensions, but anyway, that's we'll leave it. But and the other thing about ertugliflozin, which I didn't fully appreciate in terms of the amount of glucose you push out based on early studies, is actually the 15 milligram, which didn't do so well in terms of cardiovascular death. It's worth pointing out, compared to the 5 milligram dose, the lower dose, but the highest dose appears to be the most efficacious in terms of glucose excretion, and therefore presumably weight loss and HbA1c reduction. So there are some positive things to say about ertugliflozin,
Great. Amar.
The other thing is that 20% difference, that cost difference. Could you invest that somewhere else? And is that that money you're going to save there, use other things which may have more impact on cardiovascular death and mortality and all those things? Which, if we say ertugliflozin doesn't have that, well, that cost difference, could that be used towards achieving that in a different way? and perhaps in more other ways. And I think that's a strong point to argue. Is there a role for etriplosin? Yes, there probably is, and it's going to be where you place it. And as you were saying probably earlier on, I would highlight. I think one of the things that came out of this conference also was my thought process in how soon we initiate and add second therapy on in patients. I know PCDE, Primary Care Diabetes Europe, have released some guidelines out where they advocate dual therapy actually from the start, metformin plus in the beginning. And I think that's a very interesting concept, which, say, a few years ago I'd have been like, but now I'm swaying, and I think that's something interesting.
Amrit.
Yeah, I was just going to add to that in terms of at the coalface prescribing SGLT2 inhibitors. There has been confusion as to which one to prescribe when, with canagliflozin, dapagliflozin, and empagliflozin, and now we're throwing into the mix, a fourth agent. And I think it's really important that there is some cohesive kind of guidance around this. And so I'm really looking towards the ADA EASD consensus statement, which will no doubt be updated later this year, to see whether they continue their current position, which is of it being a class, with details obviously within their document. But I think for the generalist, the last thing you need is to have a fly in the ointment and thinking, well, no, hold on, which is this the SGLT2 inhibitor that I shouldn't be using in this situation? Is this, so I think that's the last thing that we want. So I'm glad you did say it's a class effect and that you go over the fence, because to an extent, it's a balance, from the academic and the statistical analysis, of which there is, a lot going on, perhaps against the hierarchical testing kind of guidance that we have, looking at secondary kind of outcomes, and actually trying to be cohesive and give straightforward guidance to the wider medical community. So I think there's something definitely to be said to stick to a class-based guidance. Thank
you so much. And I promise my very last question is: 2020 the beginning of the end for metformin? Then, Patrick.
Straight in.
Oh,
Yes.
didn't say
Yeah, I was going to say no, but I've decided to say yes.
And then one sentence, why?
Type 2 diabetes is complicated. We need medicines that have proven to work in many modalities in terms of patient-orientated outcomes.
Yeah. The reason I asked that first, I think it was the DAPA session, was saying diabetologists, primary care as well, were wedded to metformin really more with familiarity, due to familiarity and sentiment, rather than a robust evidence base. Amar, is it the beginning of the end for our dear friend metformin?
Yes, in cardiovascular disease. No, in diabetes.
Okay.
I don't think you can exclude the whole wealth of information, knowledge, and effects that metformin has proven and shown over decades.
And practical experience,
Practical experience.
Yeah.
And you can't exclude the new trials and the robust evidence we have from the current medications. So I think we'll have it separate. I think in cardiovascular patients, it may not be first line. It probably won't be where things are going. But otherwise, I don't think you could exclude it. Or maybe, as I said, a 1+1, add one straight away. So you'd be on dual.
Yeah.
But I say I'm opposing Patrick on this.
Okay. And Amrit, to finish us off.
Yeah, I think dual is a good way forward at the moment, but in 3 years' time, it might be a very different story.
Yes.
Yeah.
Good.
Can I have one comeback?
Yeah, sure, go for it.
Which is based on one of the sessions that I watched in the ADA, and it was that Alquist paper which talked about the subtypes of type 2 diabetes. Came out a couple of years ago now, and I think maybe that's something we need to revisit. I think even the diagnosis of type 2 diabetes, there are different features, and if you've got some of these patients quite clearly rapidly progress, and it is much more of a cardiovascular disease or cardiometabolic disease. They get renal disease relatively early. And for those patients, maybe metformin isn't going to be the best treatment for them. And maybe some of these newer agents are, but metformin is a very efficacious treatment, which is very good at glucose lowering, may have additional other benefits. but yeah, so we should be treating the patient ultimately.
Yeah, I mean, you're talking now about personalised medicine, aren't we? And some of the great work done by you and Pearson, absolutely. You know, that is the future, of course. Yeah, Amar, sorry.
I'll make one last point. Nothing about that, Patrick. We're even, don't worry. We're talking all about type 2 diabetes, and still the elephant in the room is that type 1 diabetes, cardiovascular disease. But we don't have anything specifically besides the standard medications we have for anyone for anything specific. So that's the big elephant in the room, and something for the future maybe.
Yeah, good stuff. Any final comments or challenges? No. Thank you so much all for your time. Much appreciated. Really enjoyed that discussion. I think we've gone on far longer than I anticipated. But it just shows we would have been doing this in Chicago, wouldn't we? We would have been having this discussion. So it's been great to chat, and hopefully we'll have another opportunity to do so again. So thanks again. Much appreciated.